Welcome to tonight's Immunisation Coalition webinar event. Our topic is exploring pertussis, whooping cough in Australia. I'm Andrew Baird and I will be your moderator. Presenting tonight's session is Professor Paul van Binder.
Thank you very much, Andrew, for the introduction, and thank you to everybody for joining us to talk about pertussis, which is becoming an increasing issue that we need more involvement from general practice in. And thank you for coming at a time when it's very difficult to have a conversation about anything other than SARS-CoV-2. I have two disclosures. One is that I've received funding for research, travel, meetings and ad board attendance from a list of vaccine providers. And my second one is that barbers and hairdressers have been closed for 2 months. So please excuse my hair. I'm hoping that at one stage that they will reopen. I want to talk initially about an overview of pertussis itself, talk about the pertussis vaccines and their effectiveness, talk about vaccination target groups and how we're doing with them, talk about priority groups for general practice, and then leave with some key take-home messages at the end of that. So pertussis as a disease varies incredibly depending on the age of the people who get it. Pertussis is a very serious disease in infants. Those people who are infected with Bordetella under the age of 1 have a 50% chance of being admitted to hospital. And of those admitted to hospital, somewhere between 1 and 2% will pass away. So this has significant morbidity and mortality in children under the age of 1. Children above the age of 1 still can show the classic signs of a repeated cough that persists and is then followed by a big inspiratory whoop from where it actually derived its name. And they can continue to have that through, although since we started giving 5 doses of vaccine to children in the first 4 years of life, we're finding that most problems are now in the adolescent group rather than the childhood group. Adolescents usually do not present with classic whooping cough, but often will present with chronic cough. And the same applies to adults and older persons. And in these people, the cough itself can last for months. And in many people, it used to be called the 100-day cough because it took 3 months before people actually were able to throw it off. You remain infectious for anything up to 3 weeks or until you've had 5 days of an antibiotic specifically targeting at Bordetella. And I'm going to spend a bit of time on older persons tonight because it's a group we do badly with. And it's a group that really we haven't had a good understanding of just how severe this disease is in that group. So if we look at pertussis notification rates, you'll see this is going back from 2000, 2016. You'll see that high notification rates in the under 1s and high notification rates in children between 1 and 14, but then it declines in people from 15 years and over from there. And part of this is what the disease is doing, and part of this is because a lot of people in adulthood who get a chronic cough don't in fact get tested specifically for pertussis, so we miss it. Hospitalisations are a different picture. These are 20 years of hospitalisations. You can see that the hospitalisations are in the ones under 1 year of age, and those who are older than that and all the way up to older persons have very few hospitalisations in that group. If we break the age groups down a bit more specifically, you can see that the under 1s are in the pink dots and the 5 to 9 are in the blue. And so we're seeing disease in younger groups. Of recent times, that green bar, which is the adolescents, has started to be more prominent within what's happening. And so we're starting to see that this waning of the vaccine after 4 years of age is producing a lot of adolescent disease. And that's why we now have a booster dose that we give in year 7 of school. If we look at the hospitalisations by age group, it's a totally different picture. You can see that hospitalisations occur in children under 1, and almost no one is hospitalised in any of the other years. The lines all run right along the bottom there by comparison. So what's been happening with our pertussis vaccines, and why is this a problem for us at the moment? Now, this is a classic pertussis graph. It's a graph that in this particular case comes from Canada, but there are UK versions and various others about. Pertussis rates were very, very high up until around about the mid-1940s. And the introduction of a whole cell pertussis vaccine at that stage produced a huge decrease in pertussis disease. And from the 60s through till about the mid and late 80s, we saw very little pertussis disease. At around about that time, there was a report in the BMJ about a group of cases seen at Greater Ormond Street Paediatric Facility talking about neurological problems associated with whole cell pertussis vaccine, and people stopped accessing vaccine. But the other issue was that whole cell pertussis vaccine was very reactogenic. We only gave it to children. It was too dangerous to give it to adults or adolescents. And so the decline and the increase in disease led to the replacement of acellular vaccine in 1997 and onwards in most countries. And so Australia now has been for 20, 25 years using various versions of an acellular vaccine, which is really just a number of proteins from the top of the Bordetella bacterium. And so pertussis toxin is one that's common to all of them, and it's one of the most important of the virulent proteins in giving the capacity for pertussis to cause the damage that it does do. So the arrival of whole cell pertussis vaccine meant that we no longer had problems with side effects, but it came at the cost of vaccine effectiveness. The whole cell vaccine was incredibly effective. The acellular vaccine, not so much. And so we've got a whole range of recommendations now for different groups, which are actually based on the fact that we've given up this very strong but very reactogenic vaccine and replaced it with a not so strong vaccine that doesn't cause much in the way of side effects. So given that that's what we're now using, who should be vaccinated against pertussis with these new acellular vaccines? And so there are a number of groups that are recommended. Firstly, all infants and children should have 5 doses of pertussis-containing vaccine from 6 weeks of age through to 4 years of age. Any children who have missed a dose of pertussis-containing vaccine under the age of 10 years are recommended for a catch-up. And the good news is that Australia has an astonishingly good paediatric infant childhood vaccination program. We run at about 95% across the country. And given that this is a very infectious disease, this has been really important in damping down disease, particularly in those who are very young and those between the ages of 1 and 10. And so it's not a priority group for general practice, because general practice already give 95% of paediatric vaccines, and general practice is doing a really good job in getting this group protected against pertussis. The adolescent vaccine, which was introduced because we started seeing a lot of pertussis in children from 10 to 19, is recommended to be given between 11 and 13 years, and it is given in year 7 in all states except South Australia. It's given in year 8 in South Australia, but essentially it's given in the first year of high school. It's a school-based program run by nurses out of councils and out of actual school systems, public health systems. It's done that way because this is a difficult group to get to all turn up at the same time to general practice to get their vaccines. And it improves coverage because it is given to them in the school itself. But we still have a ways to go with this. These are the Victorian data. 90% coverage for HPV, which is given at the same time, 85% for the Boostrix or Adacel, the DTPA. That looks pretty good by comparison to here's some data from Queensland, where their DTPA dose is only 72%. And so we're talking about a requirement to actually pick up 30% of children who need to have that pertussis booster and aren't getting it from the school. And there's not a capacity for these school programs to go back time and time again to pick up people. So there really is a need for general practitioners to understand the vaccines given at school, to opportunistically check children when they come in for different things, and to try and make sure that they're up to date with all of these, including the adolescent pertussis vaccine. Vaccines are also recommended for any adult that wants to decrease their chance of getting the 100-day cough. And ATAGI also suggests that anybody needing a tetanus-containing vaccine because they've had a tetanus-prone wound or something similar should in fact receive DTPA rather than TD. We don't know exactly how much of that goes on because a lot of that is given in emergency departments and various other spots. A lot of it is still given as DT despite the ATAGI recommendation. We think somewhere under 20%, and it may be much lower than that, actually get their booster dose. In older persons, adults aged 65 years and above are recommended to receive pertussis if their last dose was more than 10 years ago. And that applies to just about every old person who hasn't recently become a grandparent. And we think, again, the rate is well under 20% of the people who've had the vaccine in the elderly. And most of them are not getting it because it's recommended for them to have a booster. They're getting it because their children are now having babies and their children want them to have the vaccine before they actually come in contact with the newborn itself. So here's another group. Pregnant or breastfeeding women are recommended to receive a single dose of pertussis-containing vaccine in each pregnancy. And the reason for this is that we think pertussis vaccines last about, maybe 5 to 10 years, somewhere in that range. In some people, less. We've seen cases where women are not vaccinated in pregnancy and their newborns have actually got pertussis in the first month of life. And most of those have actually not had a vaccine because they were told they didn't need it because they had one a couple of years ago when they had their last baby. And so we know that the pregnant woman will not put enough antibody across to the baby if we don't top them up every pregnancy. So please try and remember, every pregnant woman needs a booster starting at 20 weeks in every pregnancy. And any woman who did not receive pertussis vaccine during pregnancy should receive one as soon as possible afterwards. The good news about this is our coverage of this has increased dramatically over the last 3 or 4 years. The study we did recently on the Gold Coast showed that 85% of pregnant women had received a pertussis vaccine in that pregnancy, which was very gratifying. Sadly, only 35% had had a flu shot, which is not gratifying, and it's something that we need to look at another time as well. Household contacts and carers of infants are also recommended to receive a dose of pertussis vaccine at least 2 weeks before they have close contact with an infant. We have no real knowledge of what the proportion of people is who get that done. We do know that parents are much more prone now to say no vaccine, no kisses to the people who are in contact with their newborns. But there's actually been a slight drop-off in those because as the pregnant women have got vaccinated and are providing protection to the newborn, they're less emphatic about saying to all the people nearby, please don't pick my baby up if you haven't had your whooping cough vaccine. Healthcare workers are recommended to receive pertussis every 10 years. Childhood educators and carers are recommended to receive pertussis-containing vaccine every 10 years. The proportion is probably under 50%. Childhood educators are a group that's tough to get them to understand they have a duty to protect the children and get vaccinated. Healthcare workers are a mixed group. The state that actually has mandatory processes, New South Wales for this, has very good coverage. Places like Victoria have no mandatory requirement. And it always astonishes me that it's possible for a healthcare worker to work in a neonatal intensive care unit with 2.5 pounds of newborn baby and not to be protected against pertussis. And the potential for somebody like that to actually produce significant morbidity in these newborn babies needing special care is such that, I don't think they should be allowed to work there if they don't have all the respiratory vaccines available to them. So what does it all mean when we look at why we're focusing on children getting regular boosters and pregnant women? And this first study for paediatrics said that the risk of pertussis was 5 times higher in children once they'd been 3 years from their last vaccine dose. So once you get to 7 or 8 instead of 4 or 5, you have a 5 times increased chance of getting whooping cough. And most of the children in that study were actually up to date with their vaccines. It's just that this is a vaccine that we purified so much it doesn't work very well. And this is a study we did in Canada where we measured all of the pregnant women at that time and measured their anti-pertussis toxin levels. 59% of them had no signs of pertussis toxin, which means that without a vaccine, they weren't giving any protection to their baby at all. And that had actually increased since the last time that study was done in 1996, when it was 50%. So pregnant women are vulnerable. They are incapable of transferring enough antibodies to their fetus through the placenta if they don't get a boosted vaccine dose themselves. So let's talk about the priority groups that we really need general practice involvement in. And the first of these is the adolescent support. As I was showing, the number of people who miss out on their adolescent vaccines varies from 30% to 15%, depending on the state you're in. And these data are actually from the good years. They're going back a couple of years. What we've had since then in places like where I am in Melbourne, about to set a new world record for the number of days we've been locked down and children haven't been allowed to go to school, is that while we've managed to keep our paediatric vaccine coverage up at the very high level it is, we've greatly decreased our flu vaccination coverage this year. And we're very worried that because we haven't been able to get the nurses into schools, because the children haven't been at schools themselves, that we're not going to be able to get anything like the sort of coverage in year 7 we need for pertussis. General practice has an opportunity to try and pick all those children up. Now, whether you selectively get a recall to get them in, children from 12 to 18 are now going to be a priority to be vaccinated with COVID. And a lot of them are going to come into general practices for that. Please, if you get the opportunity to give a Pfizer vaccine to adolescents, find out at the same time whether they've had all of their adolescent school vaccines, and please top them up a week later. If they haven't, bring them back for that. You can't give them at the same time as COVID, but it is really important that we try and cover for the fact that these last 2 years have been incredibly disruptive to children from a teaching perspective, but also from a vaccine perspective that they get in those groups. The other group that I want to spend a bit of time on is the elderly, and the reason being that we sent a message for a long time that the elderly should get vaccinated to protect little babies that they come in contact with. And in fact, the elderly need to get vaccinated to protect the elderly. because they have a real issue with whooping cough themselves. And so WHO says that the idea of vaccination is to maintain functional ability. And so we have vaccines for influenza and shingles and so on, because we know that if you contract one of those and are hospitalised, you actually lose the capacity to continue with activities of daily living, that you stop self-care and move to transitional care or something similar. And so pertussis is one of those that is involved at that time, along with flu, shingles and pneumococcal vaccines, to try and make sure that we are actually maintaining intrinsic capacity in our older persons and not only focusing on vaccines in babies. The problem for older people is that when you're born with this gland in your chest called the thymus, and it produces the thymic cells or the T cells. And as you enter into adolescence and go through puberty, your thymus disappears. And once you're through puberty, you no longer have a thymus. So you have all the memory T cells you'll ever get at that time. And the older you get, the more those memory T cells are exhausted, the decrease in fresh cells you've got available, the decrease in the CD8 killer cells that are available. And in the end, what that does, it produces a decreased response to vaccines and an increased likelihood that you will actually do very badly with the disease compared to younger people with good immune systems. So as we age, we get an increased impact of immunosenescence and frailty on disease, including pertussis, and we do badly. We know that in Australia, 75 to 80% of our elderly get flu shots pretty well every year. Half of this group have had their pneumococcal vaccines. We don't know what the coverage is for pertussis, but it's quite low. And at the moment, something like 25% have had shingles vaccines. Big boost when Zostavax first came up. And now we're looking at, the mix between people getting that and getting Shingrix, and hopefully we get the coverage up. We underestimate the burden of pertussis. People present to their general practitioner. Many people still think pertussis is a childhood disease. They present with atypical symptoms, so they don't have the classic catarrhal and paroxysmal stages, and they may just have chronic cough. They often present late. They're not that particularly sick. By the time they present, there's a challenge in actually making the diagnosis. And in many places, pertussis is not a statutory notification. And without an actual test, we'll never find out those that have, chronic cough from sensitive bronchioles after a viral illness or pertussis, or they're suspect to, some mild adult onset asthma. The diagnostic challenges remain. Culture is good in the first 2 weeks. After that, if they present with 2 or 3 weeks, taking a culture will likely get you a negative swab. PCR is good in the first 3 weeks, but then again, it decreases its sensitivity. And if you do it when they don't get better after a course of antibiotics, then you've got a very high chance of getting a negative test. The serology can be used if you've got bloods taken sequentially, but again, getting people to come back for 2 blood tests, when the single test doesn't tell you enough information is difficult. So we miss a lot of people with pertussis because it's not like a COVID test nowadays where we'll take a swab and tell you what's happening in just a few hours. What's really important is having some understanding of what's been different about immunity. In 1951, when everybody got pertussis, and a lot of it circulated, we thought your protection was pretty well lifelong. And what it meant was you kept getting boosters. It was like when everybody got measles, you were protected for life because every so often you'd come across someone with measles and you'd just tick up your antibody level again. By 1995, we thought really whooping cough disease only protected you for about 20 years. And at that stage, we were also thinking that the whole seed vaccine probably lasted maybe up to 12 years, although we worried about how safe it was. By 1997, we thought natural disease lasts about 7 to 10 years. By 3.5, by 2002, we're pretty sure that some people, in fact, could get pertussis for a second time, as little as 5 years after having disease. And we were pretty sure that the acellular vaccines that we were producing only offered protection for 5 or 6 years. And this came to a head in California one year when they had 50,000 cases, largely in vaccinated people. They had a massive outbreak because everybody's immunity had waned just enough to get them back to the stage they were when we had epidemics every 4 years. So this is the first of a few studies that I'll move through fairly quickly. This was a study of the vaccination strategy in the elderly. In 2008, 60% of the 14,000 pertussis cases were in adults, and 5% of them went to hospital. The rate of hospitalisations in adults trebled between 1996 and 2006, and those over 50 years of age had a 30% higher length of stay than adults that were younger than that. And we knew that that was still greatly underestimating the actual amount of disease over there. The case fatality rate, people who actually die from whooping cough, is higher in those over 50 than those children aged between 1 and 5 years of age. So highest death rates in very young children, particularly in the first 3 months of life, but an actual demonstrable mortality in people who get whooping cough when they're over 50 years of age. This was an epidemic July 2008 to 9 in South Australia. And you can see here the number of notifications reflect good vaccination in young kids. Children from 4 to 13, very high notification rates, but then adults having high notification rates, higher than all of the children, and 66% of disease in adults over 25. This was a particularly disturbing study that was done in a whooping cough outbreak in very old people in a religious institution. It was a convent in the Netherlands. 49% of people were positive out of that cloister, 47% in those under 74, 58% in those over 70, 75 and above. 5% death rate in these very old people who got whooping cough in the Netherlands. And all of them were due to intracranial bleeding. And they coughed on average between 103 and 236 days. And while we always knew before this study that old people can actually break ribs if they're infected with pertussis and they just cough continuously, this was the first really good example that we had that people actually died from strokes from continuing to cough with pertussis. And, a key message for general practice is that elderly with nocturnal prolonged periods of coughing, we must consider the diagnosis of pertussis in them. And this was a study where they actually looked at elderly community residents. They did a serological study over 3 years. And they actually started with a group of people that didn't have disease, and they took bloods on a regular basis. And they looked for an increase in the pertussis toxin titer or specific titers to fimbrial antigens. And what they found was that the rate of getting pertussis in that group was between 3 and 8% every year. And 50% of them actually had definitive time-associated symptomatology. So symptomatic pertussis occurs in elderly individuals, and we need to make sure they get boosted doses of vaccine. This is the issue of other things that make it worse. So 87% of those in hospital with pertussis in the US in this particular study had one or more other conditions, obesity, smoking, asthma, COPD, and so on. And all of the pertussis deaths in that study occurred in patients with underlying medical conditions. These are asthma studies in Minnesota and New South Wales and more broadly in the US. And you can see your likelihood of having pertussis if you're asthmatic was from about 2 times to 4 times than if you weren't asthmatic. This was people with COPD, and they were 2.5 times more likely to be hospitalised with whooping cough than those people without COPD. This is the issue in immunosuppression in a range of studies in Spain, Norway, the US. And what they found was that you're about 6 times more likely. The immunosuppression rate was 3%. The hospitalisation rate for pertussis for those with immunocompromising conditions was 20%. And this is obesity, which is being increasingly seen as an issue for all of the conditions we've been talking about lately. We know that they do worse with flu. We know that they could do worse with SARS-CoV-2, and this is saying that they have a 1.5 times more likelihood of pertussis if they're obese than those who are of normal weight. So just towards the wrap up of this, the effectiveness of pertussis vaccination, the duration of immunity, 80% effective in the first year. Still very good from 1 to 3 years. 4 to 7 years, it's down to 60%, and 40% at 8 or more years since vaccination. And so at the moment, my recommendation to all my patients is that every 10 years you need to have a whooping cough booster. And the only group that I change that for is healthcare workers, people in paediatrics, people in childcare, people working with vulnerable individuals. I actually believe that they need to have a booster dose every 5 years just to make sure that they're not producing a risk to the people they look at. So the antibodies that we have left are minimal. There is lots of disease. Much of the disease is unrecognised in general practice, and there's actually a defined mortality of whooping cough in older people. And now that we have such good vaccination rates in pregnant women and babies, we actually have more problems with old people dying of whooping cough than we have with very small babies. And so we need to make sure that we have recurrent vaccination available. And these are slides from a couple of articles that I'll go to in a second that were published in Medicine Today in a supplement that we put out on old people a couple of years ago. We need to develop an awareness and a belief in the significance and severity of disease. If we don't understand this is nasty, we won't do anything about it. We need people to understand the vaccines are effective and safe. We need to fund the vaccines, and that's a real issue with whooping cough because most of the groups that we talk about, apart from pregnant women and young children, the vaccine is not funded under the NIP, so people are having to talk about the cost. We needed a broad-based program that says that this is available in all general practices and we're all thinking about it, and we need to have a better monitoring system so that we know what's going on. And these are 2 articles, one that Michael Woodward and I wrote. In fact, both Michael Woodward and I were involved with, and it gives you tips for how to talk to older patients about pertussis vaccinations, talking to them about the risk, about how serious it can be, about how effective it is, how long protection lasts, and what the adverse effects are. And in fact, the risks are very, very low with vaccines. And the other bit is, how do you address specific questions? I wasn't aware that I needed vaccination. I was vaccinated as a child. Why do I need another? Vaccination doesn't stop me getting disease. I had whooping cough 10 years ago. I'm concerned about the adverse effects. Now, these articles are available on the web. They were made open IP, but also this presentation will be available to people after the presentation tonight, and you'll be able to have a look at this slide in particular, so you've got some idea about how to talk to the older patients and how to actually get them getting enough information so that they get vaccinated themselves. So in summary, pertussis occurs in all age groups. It's frequently underreported in adults. Adults with underlying condition are at increased risk, and they have worse symptoms and hospitalisations. Pertussis can worsen the symptoms of underlying disease and significantly increase healthcare costs, as well as longer lengths of stay and actually decreasing your overall quality of life subsequent to having the disease, particularly if you're hospitalised. There's some references which are available there on the slide, which will be available afterwards. And on that note, I'm happy to stop, go back to Andrew and answer any questions.
Great. Well, thank you very much, Paul. Fascinating presentation. Thank you for sharing your knowledge and your insights, and for giving some very clear advice and messages and practical strategies for primary care. So many thanks indeed, Paul. Thank you. Excellent for your contribution. We do have a number of questions which have been submitted, and I would like to welcome everyone to continue submitting questions. We will try to work through all the questions that have been submitted, but very welcome to submit some more questions. So please stay for our discussion well, on the questions. We'll extend the presentation and build on some of the points that Paul has discussed in his presentation. So perhaps I could start with a question. In fact, it was there are two people, Anne and Nadine, have asked a question, and it's around funding. And their questions are very similar. So they're pointing out that the DTPA vaccine is not free, unlike DT, and that this may be a cost deterrent. Perhaps we need to fund it for everyone. Paul, what are your thoughts?
Yeah, no, look, I absolutely agree that it's a deterrent. In the suburbs where I am, the cost of DTPA varies from about $37 at the cheapest point through to $65, depending on which practice, you know, whether you write a script or have it in your fridge and so on. So this is not insignificant. I think one of the disappointing things about the Australian vaccination program nowadays is that increasingly really important vaccines, meningococcal B vaccine for children, Shingrix, which is a very effective vaccine, pertussis boosters for many people, are not free, and they should be free. I mean, I think, you know, we just spent $900 trillion on COVID response, but we can't fund, you know, $35, $40 vaccines from the government price. And so I think it's disappointing. I'm not telling people to sneak some of their NIP to pensioners who can't afford it, because that would be an inappropriate comment for me to make during a webinar. But, you know, I think this is something that I come up against time and time again. You know, the best I've negotiated for Shingrix is $520 for the 2 doses. Now, you know, for people 50 to 65 who are working and whatnot, that's probably something that they can do because it's such a nasty disease. It's one of the reasons we have to convince people that pertussis is actually nasty. You don't want a 100-day cough. You don't want to break a rib, and you certainly don't want to have a stroke as the end of this. But I totally agree with the commentary of people that as a wealthy country, there are a lot of vaccines that we should be funding that we don't. And I'm also disappointed about the recent changes to pneumococcal vaccines. You know, we've stopped letting anybody at 65 actually have free pneumococcal vaccine. They have to wait to 70 and get the other vaccine, and they still need Pneumo 23, but they have to now pay for that as well. So I think, you know, we need to get some focus on this at some stage with Greg Hunt and others to say, you know, we're spending literally billions of dollars on COVID vaccines. And I'm not saying that we don't need COVID vaccines, but I think, spending an extra 20 million on some of the ones that we're not funding is really important. We've got some vaccines now that the federal government was dragged kicking and screaming towards. Every state funded paediatric vaccination for flu, and then finally the federal government decided to pick up the tab, even though that's their role. Meningococcal vaccine for adolescents was funded by the states, and finally the federal government decided to do it. So there's been a range of these cocoon strategies originally for pregnant women. I just think that from 20 years ago, back in the times of the first immunisation plan with Minister Woodward, we've now gone to a process where, we can't hold our hands up and say we're the leading country when it comes to this. And we should get our organisations, the colleges and the rest of it to actually make a case to say, come on, we can do better.
Thank you, Paul. And I think that's a call to arms, that we need to be literally to arms. We need to be out there and getting arms injected. And of course, in terms of cost deterrent, in general practice, there may be a fee for a consultation too. So it's not just the cost of the vaccine itself. So thank you, Paul. There are a couple of questions now which relate to interval between doses. So there's a question from an anonymous participant. How often should we be giving boostrix to adolescents and adults? I think to some extent you'd answered that in the presentation.
Yeah. And so the official recommendation is people should have a booster after 10 years. As I was saying, I vary that for what I consider high-risk groups of transmission of pertussis, healthcare workers who are working with children, childcare workers who are working with children, people who are working with vulnerable disabled groups and so on. And I think because this is not our strongest vaccine, I recommend they get boosted every 5 years. But as a general principle, we should be giving booster doses every 10 years to all of our adults.
That's a very clear message. Thank you, Paul. And the follow on from that, for an adult close contact, how recent does the last dose need to be? Within 1 year or 2 years or 5 years or 10 years?
I think if someone has had vaccine and then they come across a case of pertussis, then if they've had a vaccine within the last 10 years, because of the lack of severe morbidity in adults and adolescents, then I'd be comfortable that they don't need to be boosted. And in fact, they may get some boosting from being in contact with somebody like we used to with all of the measles that circulated around. And so I think that's reasonable in that setting, with the proviso that they should be advised that if they get a cough, because the vaccine hasn't worked, they should see their general practitioner early, because 5 days of an antibiotic early on will prevent transmission from those people to other people and will help us get on top of whatever's going on in the community.
Excellent point, Paul. One of the dilemmas we have in general practice is recognising it early. It tends to be diagnosed further down the track, by which time it's too late.
Absolutely. Yeah.
Yeah, but it's just having a level of clinical suspicion to be thinking of it. Another question, please, Paul. This is from Catherine, and again, it relates to the booster interval. Should we be encouraging adults to be getting the booster every 7 to 8 years rather than every 10 years due to the waning immunity of the pertussis vaccine?
Look, I actually think that's reasonable. I think the challenge is that as much as possible, I try to stick to the recommendations of ATAGI. I mean, we have the Australian Technical Advisory Group on Immunisation, and while at times I'm frustrated with their decisions like pneumococcus recently and so on, they've set the guideline at 10 years. I mean, it's I think getting to the end of how good this vaccine is, but I think messages that, why don't we do 7 or 8 but 5 for kids and whatnot, gets too confusing. You know, I think one of the safe things for general practice is follow the ATAGI guideline, and it's only in special circumstances that I actually vary that. You know, so, and I get a lot of these questions: when should we give a second flu vaccine in a bad year? You know, how early should we give a dose of whooping cough booster, and so on. I think follow the ATAGI guidelines as a general principle, but then there are situations where on a clinical basis, you make a decision that in fact I might want to give something a bit earlier, or I might want to give a second flu shot because you've got COPD and you're in hospital last year and so on. And your flu vaccine was 5 months before the flu actually arrived, so I don't think it's going to be working very well anymore. You know, so I don't think guidelines take away the capacity of general practitioners to make clinical decisions about what they're seeing in front of them.
This is a question about guidelines, and this is about COPD-X and the asthma guidelines. Co has pointed out that there are no recommendations in relation to pertussis vaccination, unlike influenza and pneumococcal vaccination, in the elderly with COPD or with asthma. Is there a reason for the lack of a recommendation for pertussis in these, of which you've acknowledged in your presentation, are a high-risk group, elderly people with respiratory?
Yeah, and look, I think what happens is people write guidelines based on the information that they're familiar with. And if the people writing the guidelines are not familiar with recent data to do with pertussis, then it doesn't appear there. But it's not because it shouldn't, it's because it just didn't at the time appear there. There are real pushes now through the International Federation of Aging, through a whole range of groups that are looking specifically at vaccination policy around the world. And they've got a view that we have a very ageist vaccination policy. You know, we're really focused on these young children, and we need to make sure they don't get, you know, measles and all of the other nasty diseases when they're young. But we also need to reflect the fact that there are 4 key vaccines for our elderly and for those with chronic diseases: pneumococcal, pertussis, influenza, and in those 50 and above, shingles vaccine. And although some guidelines don't incorporate that, I think the importance for general practice is that we've got to get to a point where all of those are considered in older persons, and that we're starting to make that part of our reviews. You know, whether it's late when you're doing a 75-year review or whatever, I think there are real opportunities. These, unlike these teenagers, these are a group that really do present to general practice a lot. And so we do have opportunities to say, you know, why don't we review your other vaccines? You've come in for your flu shot. I notice you haven't had your pneumococcal vaccine yet, and you haven't had a booster dose, you know, and so there's a real chance. I think one of the challenges that we've seen in Australia is that 80% of people come almost every year for their flu shot. And a lot of them have never had a pneumococcal vaccine, even though it's recommended and you know, funded in some way. And so I think a broader approach to vaccination in the elderly is really important for us to come to terms with.
Thank you, Paul. I'd like to ask a question from Richard. And Richard's asking about any information, any data and separate requirements for First Nations people, people living in rural areas, and for refugees. And the issue around refugees is about you know, catch up, where we're not sure about vaccination histories.
No, and interestingly, the issue of refugees and catch-ups is really important, and it's addressed variously in different places. This is one of the, I think, shame areas of Australia, that we haven't had a policy of funding total catch-up for refugees. I know that some states do provide state funding for catch-up for refugees, and I think it's incredibly important that people go through their vaccination records and put them onto a catch-up program to make sure. I think part of the central approach to this was they're only a danger to themselves. You know, they've picked up something in the Nigeria refugee camp before they come over. We focus on the things that they don't spread, you know, so they will get a TB check in case they give that to somebody. But if they turn up with measles or something, the rest of the community is vaccinated, and so they're not posing a risk. So they're not funding that. Whereas really from a moral and ethical point of view, we should be catching up all the refugees that we come across. And there's usually ways to get access to vaccine in some way, so that we're not saying, well, here's your catch-up program and here's your $2,000 bill for your Hexa and everything else. This is one of the areas where we don't have a specific Indigenous recommendation to do extra, but the 5 doses that they get in the first 4 years of life, and then the catch-ups that they get, they don't have a higher rate because of that early vaccine than we see. Whereas with pneumococcal disease, with flu and so on, they have a much higher rate. And we actually have specific recommendations that all Indigenous people get a flu shot, and it's funded, whereas many non-Indigenous people are recommended to have a flu shot, but it's unfunded. So it's not specific to these groups, but I agree with what you're saying, that we need to make sure that we do things for groups like refugees coming to Australia.
And Rich has also referred to another group, and that's people in rural communities. Are there any special requirements or recommendations for those in rural areas?
There aren't, and it depends on the rural community. I've sadly left the Gold Coast 20 months ago and moved to Lockdown Central in Melbourne. And we got here just in time for the start of the pandemic and the daily 5-kilometre walk from our house. The issue on the Gold Coast was that we had clusters of whooping cough on a regular basis. We had a group of people in the hinterland of the Gold Coast who were part of that northern New South Wales anti-vaxxer group. And so they need more vaccine because they didn't have any vaccine. And so they were 3% of the population, and they varied from 40 to 60% of our cases on the Gold Coast. And so rural areas, if they have good vaccination coverage, do just as well as city areas. They don't need anything special, but it relies on good early vaccination coverage. And, clearly the Byron Shire is a rural area that is a problem. The hinterland, Fremantle in WA and so on, north Sunshine Coast.
Yeah. Thank you, Paul. And I think we've got time for one more question before we close. And this is a question from Suzanne. And the question is, can adults be infectious while asymptomatic, or will they always have a cough when they're infectious?
Yeah, and adults can be infectious for up to 3 weeks. Usually they have a cough. And so we haven't seen good data that asymptomatic people are transmitting pertussis. If they don't have a cough, they're not likely to do it. They're infectious until 5 days of an antibiotic or for 3 weeks. So if they've been coughing for 2 months, they're not going to give it to anybody. They're just going to drive themselves nuts or their partner nuts when they cough all night. But it's not infectious, if you're asymptomatic at that time, unlike coronavirus, which you're infectious for a day or two beforehand, particularly with the Delta strain. And unlike influenza, where again, you're infectious for a day before you actually produce symptoms. We're not seeing the same thing with pertussis, although you may, in the immediate pre-symptomatic period, transmit bacteria at that stage.
Thank you, Paul. I wish to thank Paul very much for a tremendous presentation and discussion with our questions and answers. We have been given some very clear messages and some very practical strategies to help us in primary care. The one that I've picked out there is being opportunistic, being more opportunistic in our approach to getting pertussis vaccination for our general practice population. Thank you very much to you as our participants for joining the webinar. Thank you very much, everyone.